you have chosen the best speakers in the country. So, accept my congratulations. Now, I will ask Mr. Manish Bansal, who is going to teach the students cardiomyopathy, which is a very important subject. And it is a privilege for me that these classes are going very well. ICP is doing very well in conducting these classes. Thank you, Ajay. Thank you, Mr. Bansal.
Thank you, sir. Thank you, sir. So
Okay.
let me thank all the API stalwarts who have driven us to do this, especially Dr. Tiwari, who's the backbone of this program. And this program comprises of different faculty, different facilities like cardiology, respiratory medicine, uh, infectious disease, so many part of it. And now recently he has just started beautiful yoga classes for under his banner every Sunday morning from 8 to 9. So that is wonderful. That is something wonderful. Dr. Manish, if you have time on Sunday morning, you or anybody can join and you will see the kind of uh, mm, uh, material in that. So
Sure.
let me introduce, I mean, you don't require any introduction, Dr. Manish. Uh, you are extraordinary. You are very highly talented man. You are serving Medanta as vice chairman uh, of Medanta cardiology, and he has been coming to Patna frequently, especially the Medanta program. And I thought, who would be better than Manish Bansal to speak on today's topic, that is cardiomyopathy, which should be known to all of us. So over to you, sir.
I'll just share my slides first. So first of all, I would like to thank Dr. Sinha for giving me this opportunity and for a very, very kind introduction. I also thank the API leadership, including Dr. Tiwari, for creating this platform. It is an absolute privilege for me to speak in this forum and on a topic as important as cardiomyopathies. Cardiomyopathy actually is a very, very broad topic. So I'll try to give the overview of the specific cardiomyopathies. But before that, we'll briefly talk about the cardiomyopathies in general. Now, cardiomyopathies, as we know, is a group of diseases that comprise hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic RV cardiomyopathy, restrictive cardiomyopathy, and so on. Now, this is a group of disorders that we encounter in our daily clinical practice quite frequently. These are associated with significant morbidity and mortality. But in many of these conditions, if we diagnose them in a timely manner, we can do a lot of corrective things and we can offer many treatments to our patients and can improve the clinical outcomes. And therefore, it becomes very, very important to have an understanding of cardiomyopathies. So first of all, how a cardiomyopathy is defined. So cardiomyopathy is defined as a myocardial disorder in which the heart muscle is structurally and functionally abnormal in the absence of CAD, hypertension, valvular disease, and congenital heart disease sufficient to cause the observed myocardial abnormality. So basically, it is a primary disease of myocardium. As per the current classification, cardiomyopathies are divided into five broad categories: hypertrophic cardiomyopathy, dilated cardiomyopathy, ARVC, restrictive cardiomyopathy, and non-dilated LV cardiomyopathy. This last entity is a new term introduced recently by the European Society of Cardiology. This term includes many vague type of entities or varied type of entities like arrhythmogenic cardiomyopathy, arrhythmogenic LV cardiomyopathy, or sometimes even dilated cardiomyopathy. These are the patients who have some form of myocardial abnormalities, but LV is not dilated, LV is not hypertrophied, and there is no feature to suggest restrictive cardiomyopathy also, but they are at risk of having arrhythmias mainly, and therefore identifying them as having a cardiomyopathy becomes important. So, non-dilated LV cardiomyopathy is actually an entity which is defined by the presence of either non-ischemic LV scarring or fatty replacement, which is diagnosed using MRI, or isolated global LV hypokinesia, which can be diagnosed using echo or MRI, in the absence of CAD, hypertension, valve disease, or any other condition which could explain these abnormalities. So basically, there is abnormality of myocardium, either in the form of structure or mild global hypokinesia, but there is no LV dilatation. Then we call it LV cardiomyopathy. And most of these patients present with some form of arrhythmia or have family history of sudden cardiac death. The understanding about cardiomyopathies has improved significantly over the last 1 decade because of advances in the imaging modalities, genetics, and there have been improvement in therapeutics also. Now, as per the current understanding, whenever we suspect a cardiomyopathy, we need to follow a systematic approach to reach a diagnosis. So the diagnostic process will begin with initial suspicion, which may arise either because the patient has presented with some symptoms which could be related to cardiomyopathy like dyspnea, chest pain, palpitations, syncope, or they may be family history of sudden death. Or sometimes it is because of ECG abnormalities like VPCs or arrhythmia on Holter that we uh, suspect a cardiomyopathy. Now, once cardiomyopathy is suspected, the next step is to characterize the phenotype. And for that, we use echo. Echo is the primary modality. And in many patients, we need to be using MRI also. Based on that, we can decide whether the entity that we are seeing fits in with HCM or DCM, ARVC, RCM, or non-dilated LV cardiomyopathy. Now, once we have reached this stage, then we have to look at other associated abnormalities. Like in some cases, we may have to do arrhythmia workup, as in case of hypertrophic cardiomyopathy or non-dilated LV cardiomyopathy or ARVC. We may have to do genetic testing, family screening. We may have to look for extra cardiac involvement, as we have to do in cases of restrictive heart disease like amyloidosis, which is not a true cardiomyopathy, but mimics RCM, laboratory testing, other abnormalities that we look at. And based on all this assessment, we reach the final diagnosis. So here is one example. So this is a 17 years old gentleman presented with palpitations. He had family history of sudden cardiac death. His clinical examination was normal. Echo was done. It was broadly normal, a normal LV size, EF. So he underwent MRI. MRI showed a subepicardial scar. Now, obviously, a scar in a patient who's otherwise healthy, a myocardial scar, is not a normal finding. ECG showed some degree of intraventricular conduction defect, which again points towards the presence of cardiomyopathy. And Holter showed VPCs, not frequent, but there were VPCs. Then genetic testing was done. It showed a mutation in the desmoplakin gene. So all this establishes that he has a cardiomyopathy. And because he does not have LV dilatation or hypertrophy, this will be labeled as non-dilated LV cardiomyopathy caused by desmoplakin gene mutation, which is autosomal dominant with subepicardial scar and low normal LVEF. So this is how we need to diagnose a cardiomyopathy. Now, in a diagnostic workup, when we suspect a cardiomyopathy, ECG plays a very, very important role as the initial diagnostic tool. If we find any conduction defect or any QRS fragmentation, then we should be strongly suspecting some form of myocardial disease. Like as you can see here, this QRS fragmentation suggests that this myocardium is not healthy. On the other hand, in dilated cardiomyopathy, if we find left ventral branch block with QRS duration more than 130 millisecond, then that is an indication for CRT. As we all know, CRT is a life-saving treatment in patients with DCM. So ECG is a very important modality. Besides this, we can find frank arrhythmias also, as in case of hypertrophic cardiomyopathy and other entities. After ECG, we usually go for some form of imaging. As I mentioned, echo is the primary modality, followed by MRI in most of the patients with cardiomyopathy. And these two modalities will help us reach a phenotypic diagnosis of cardiomyopathy. Then this can be followed by other imaging tests as needed. We may have to do CT angiogram to rule out CAD. We may have to do invasive angiogram. If we are suspecting ATTR amyloidosis, then bone scintigraphy will be required. If sarcoidosis is suspected, then PET scan, whole body PET may be needed. So the evaluation approach will have to be tailored according to what we find on the initial assessment. Cardiac MRI, as I mentioned, has become a very important modality in the evaluation of cardiomyopathies. It is a class 1 indication, actually, and therefore, in most of the patients, we should be performing cardiac MRI, except maybe some situation like typical LBB associated DCM, where we don't need to do any extensive workup. We know that LBB is the cause of DCM in those cases. Here are some examples of MRI findings in some cases of non-dilated LV cardiomyopathies. So as you can see here, in many of these cases, there is this late gadolinium enhancement, which indicates myocardial scar. In some of these conditions, there is a typical ring-like subepicardial scar, like in desmoplakin gene-related cardiomyopathy, in phospholamban entity, and then in filamin, this ring-like uh, LG. This is strongly suggestive of genetic cardiomyopathy. So if MRI shows this kind of pattern, we should be going for genetic testing to identify the gene which is involved. In some cases, there may not be any LG, or sometimes there may be patchy LG involvement. Then we do some laboratory investigations. Some of them are going to be standard, like renal function, liver function, NT-proBNP, troponins, and so on. But for some specific forms of cardiomyopathies, additional tests may be needed, like thyroid function, vitamin D, etc. for DCM. And for RCM, we may have to look at serum iron, urine and plasma protein immunofixation, free light chain. These are so this table shows the tests which are needed in every patient with suspected cardiomyopathy, depending on what phenotype we have encountered. And these are additional tests which may be needed on a case-to-case basis. Genetic testing has again become very important in the evaluation of cardiomyopathies, and many patients will need it either to diagnose the entity that they are having, then for prognosis assessment, because there are some genes which are associated with worse prognosis, like laminin in case of DCM. If it is abnormal, if there is a mutation in laminin, then patients have a more malignant course with rapid progression and high risk of SCD. So they may be an indication for prophylactic implantation of ICD. But it's very important to remember that genetic testing should be offered only by those who have got sufficient understanding of genetics, because many times we come across mutations which are not related to the primary disease, and then we are clueless and it creates confusion and unnecessary apprehension. So the person offering genetic testing should have sufficient knowledge of this field before it is offered. And once all this evaluation is done, then based on what we have found, the patients are treated. There are certain treatments which apply to all types of cardiomyopathies, and then there are some which are specific to specific cardiomyopathy, like LVOT, obstruction management in case of hypertrophic cardiomyopathy, and ICD also needed in them. CRT will be needed in some patients with DCM, and likewise. So with this overview of cardiomyopathies, the definition, the classification, and a broad diagnostic approach, let us now look at some of the specific cardiomyopathies. I'll be talking about dilated cardiomyopathy, hypertrophic cardiomyopathy, and restrictive cardiomyopathy. I will be skipping ARVC and NDLVC for the purpose of this meeting because of the time constraints. So dilated cardiomyopathy is one of the commonly encountered cardiomyopathies, which we all have seen this in our clinical practice. It is defined by the presence of LV dilatation and systolic dysfunction, which is unexplained solely by abnormal loading conditions or CAD. There are specific cutoff values given for LV dilatation. Um, for diameter here in the guidelines, they have given absolute values, but we know that Indians have smaller body size, so we should be using index values, and therefore these volumetric cutoff values are going to be more helpful for us. Systolic dysfunction is defined as EF less than 50%. So if there is LV dilatation or EF less than 50% in the absence of a condition which could explain this external condition, then we label this as dilated cardiomyopathy. There are numerous causes of DCM. It can occur as a result of infections, toxins like alcohol, some hormone disorders, nutritional deficiencies, electrolyte abnormal disturbances like hypocalcemia can cause it. It can occur as a peripartum complication. Many autoimmune diseases can cause it. Some drugs can cause it, particularly the cancer chemotherapies like anthracyclines, and LBB itself can cause dilated cardiomyopathy. The patients with DCM will present either with features of left or right side congestion, or they may come to us with arrhythmias or thromboembolic events, or may present to us with history of sudden death in their family. Sometimes the patient's first presentation is sudden death itself. Echo is the initial test that is done, and it will immediately show us dilated dysfunctional LV. As we can see here, there's severe global LV hypokinesia. Although most patients have global LV hypokinesia, but in some patients we may have an impression of regional wall motion abnormalities, as we can see here, and which can be mistaken as inferior wall myocardial infarction. But this is a common occurrence in patients with LBP and DCM, so we need to be aware of this. Once we diagnose that there is LV dilatation and dysfunction, then echo can provide us a lot of additional information like the status of LV filling pressures, uh, PA pressure, overall LV size, shape, geometry, the presence of MR. We can look at strain also, which has prognostic value. So a lot of valuable hemodynamic information can be gathered, which is helpful for treatment of these patients. But two important findings that I'll talk about are first is MR, functional MR. MR is very common in patients with dilated cardiomyopathy. It occurs because of tenting of the leaflets. The leaflets become tented because as the LV dilates, papillary muscles move away from the mitral annulus. And because the length of the cord is fixed, so they are not able to allow the leaflets to go up to the annular plane and go out. So they remain tented within the LV and they are not able to close properly. And because of that, MR occurs. Now, when patients have severe MR, then they will need some form of intervention. Initial management will be medication, but the MR, which is a kind of MR that we can see here, will not be manageable with medicines alone. So, in such cases, we will have to go for either some surgical intervention or percutaneous intervention, such as MitraClip. The other finding that can be helpful in deciding about management is this kind of pical rocking, which we see in patients with left frontal branch block. As you can see, this LV apex is rocking sideways. When this finding is present, this indicates very good possible probability of response to CRT. Although the decision to go ahead with CRT is not going to depend on echo findings, but at least the presence of this finding is very reassuring that if this patient is treated with CRT, he or she is likely to greatly benefit from the treatment. Then all patients will need additional workup in the form of lab investigations, which I already mentioned. Cardiac MRI will be needed in many patients. In most of the patients, we will have to do some form of coronary imaging, either invasive CAG or CT to rule out CAD, and genetic testing in selected individuals, especially if there is family history of cardiomyopathy. Management of DCM includes guideline-directed medical therapy, including ARNI, beta blocker, SGLT2 inhibitor, and MRA. plus other medicines as needed. And then in some specific conditions, specific therapies in the form of CRT or correction of metabolic or hormonal abnormalities, immunosuppressive therapy, etc., will be needed. And when the disease is far advanced and the patient is having end-stage heart disease, then we will have to consider uh, treatments like ventricular assist device or cardiac transplant. Now, the second very important cardiomyopathy is hypertrophic cardiomyopathy, which is actually the commonest inherited cardiac disease with the prevalence of 1 in 500, that is 0.2% in the general population. So it's a huge prevalence. 60% of all cases of hypertrophic cardiomyopathy are caused by mutations in sarcomere genes, which have autosomal dominant inheritance. It is also the commonest cause of sudden death in young adults, and we have all seen hypertrophic cardiomyopathy quite routinely in our practice. So, when to suspect SCM? So, the suspicion of SCM may arise if we come across a patient who's got typical ECG changes in the form of deep T inversion in precordial leads along with LVH. The patients may present to us with palpitation, dyspnea, chest pain, or they may be documented arrhythmia. They may be family history of hypertrophic cardiomyopathy or SCD, or we have done echo for some purpose and we find LVH that we start suspecting hypertrophic cardiomyopathy. So, how to define hypertrophic cardiomyopathy? Hypertrophic cardiomyopathy is defined as unexplained LVH with LV wall thickness 15 millimeter or more in any one myocardial segment using any imaging modality. It may be MRI or echo. But in patients who have got gene mutation present or family history of hypertrophic cardiomyopathy, then even 13 millimeter wall thickness is sufficient to diagnose hypertrophic cardiomyopathy. So when we see hypertrophic cardiomyopathy, there are certain echo findings that we look at. First is the LVH, extent and pattern of LVH. Second is going to be LVOT obstruction. And third is mitral regurgitation. And then LV systolic and diastolic function. So as we can see here, there is asymmetrical septal hypertrophy, quite classical of HCM. This anterior septum is markedly thickened, posterior wall is not so much thickened. So this is the most common type of LVH that we see in hypertrophic cardiomyopathy, seen in almost 50% cases, but there are many other variants that can also be seen. So here there's thickening of only IVS. No other segment is thickened. As you can see, IVS is thickened and posterior wall, lateral wall, and anterior wall are not that much thickened. Here there's thickening of only the inferior wall. In this example, only anterior wall, and so on. So there are many different patterns, but the commonest is when the septum is thickened markedly. The rest of the LV is also thickened, but the posterior wall is not thickened. Now, although the presence of ASH is highly suggestive of hypertrophic cardiomyopathy, but we need to remember that a similar appearance can occur in many other conditions also. Like sometimes it is a pseudo hypertrophy, such as a patient who's got LVH and then suffers inferior posterior MI. So posterior wall is thinned out, but septum remains thickened, and it will give an appearance of asymmetrical septal hypertrophy. Then RVH can lead to ASH. Anomalous muscle bundles can give an impression of asymmetrical septal hypertrophy. Sigmoid septum, LVH of elderly can also create a similar confusion. Then any condition which can cause concentric LVH can also cause ASH, like cardiac amyloidosis, LVH secondary to hypertension, aortic stenosis, Fabry's disease, or storage disorders. So here is an example of a patient who had concentric LVH but then suffered posterior wall MI. So now we get an impression of ASH, but this is actually not true ASH. In this example, septum appears to be thicker than posterior wall because of the presence of this RV muscle bundle. So we need to be careful about this. Now there are two very specific pattern of HCM, of LVH that are seen in HCM and often mistaken or missed. So one is apical SCM, which is a common form of SCM seen in Asian individuals. These patients have typical ECG pattern characterized by deep T-inversion precordial leads. Very often they undergo angiogram. Because of these ECG changes, angiogram turns out to be normal, and then they are sent home without realizing that this could be because of apical hypertrophic cardiomyopathy. Now, the confusion also arises because echo is also deceptive in these patients. So, as you can see, this is a Plex image. Now, in Plex image, we don't see LV apex. So, this image looks absolutely normal. If we don't look at LV apex, we will completely miss apical hypertrophic cardiomyopathy. If we tilt the transducer, then we can appreciate that although basal parts are not thickened, but apex is thickened. Now, in apical views also, it may not be that easy to pick up uh, uh, the thickness of the apical segments, because here the LV wall is parallel to the ultrasound beam, so endocardium is not seen. So if anyone looks at this image, he or she may get an impression that there is apical aneurysm. But actually, there is significant LV hypertrophy, which we may be able to appreciate if we tilt the transducer or if we use color Doppler. So this color Doppler can quickly tell us that the cavity size is markedly narrowed near the apex and it is broad at the base. So this color is giving an appearance of spade as in the playing cards, and that's why this is also known as spade-like cavity in apical SCM. If we have contrast, ultrasound contrast, then the diagnosis of apical SCM becomes very easy. But if we don't have that, we can take the help of strain imaging also, which will show us dropout at the LV apex. Because whenever there is any myocardial disease, strain is reduced. So here there is apical myocardial abnormality. So strain will be reduced at apex. So this appearance can also give us a clue towards the presence of apical SCM. The other characteristic pattern of hypertrophy is mid LVH. As you can see here, there is significant hypertrophy of the mid part of the LV, and then there's apical aneurysm. So this is an entity which is associated with high risk of sudden cardiac death. So we should not miss it. In these patients, the Doppler trace is also very characteristic. As you can see, it is a bifid type of signal known as lobster claw appearance, quite suggestive of mid-ventricular hypertrophy. So after defining the severity of LVH and the pattern, the next thing that we look at the LVOT obstruction. The commonest cause of LVOT obstruction is systolic anterior motion of the metal leaflets. So as you can see here, during systole, when the valve closes, the tip of the leaflets turns towards the septum. Many reasons are there. It's combination of reasons lead to this SAM. So it's abnormality of the mitral valve apparatus itself, which produces a drag towards the septum. And it is partly because of the Venturi effect also created by the rapid flow into the LVOT. So this kind of SAM results in LV outflow obstruction, which is typical of hypertrophic cardiomyopathy. It is a dynamic obstruction. As the LV contracts, obstruction develops. Now, apart from SAM, LV obstruction can also occur because of the thickened papillary muscles abutting the septum or very small LV cavity. As you can see in all these images, there is significant turbulence in the LVOT, indicative of LV outflow obstruction. When we put Doppler cursor across LVOT, we find this kind of trace, which is a late peaking signal, dagger shaped, which is again very typical of dynamic obstruction seen in hypertrophic cardiomyopathy. In patients in whom there is no significant gradient at rest, we should try to do some maneuver to provoke it. The maneuvers commonly used are Valsalva maneuver or just asking the patient to stand up from supine position. These maneuvers can precipitate LV outflow gradient. In some individuals, symptoms appear mainly after meals. So in them, we can ask them to have a heavy meal and then come back. And if we do echo again, we may find significant gradient which was not there earlier. The presence of gradient is very important for us to look at because based on gradient, we decide whether we are going to call it non-obstructive SCM or obstructive HCM. And the cutoff value is 30 millimeter mercury or more. If there is no gradient or at least less than 30, I mean, at the most less than 30, at rest and on provocation, then we call it non-obstructive SCM. So as we can see here, this is a patient who's got LVH. ASH is there, but there is no SAM of the mitral leaflets. LV outflow also does not appear to be narrow. So this patient did not have significant gradient. The next important abnormality in HCM is MR, which is common. MR occurs because of a variety of mechanisms, including SAM. Because of SAM, the leaflets are dragged towards the septum, so it causes distortion, non-cooptation, and MR. Now, typically, this MR is posteriorly directed. If MR in hypertrophic cardiomyopathy is not posteriorly directed, if it is centrally directed or anteriorly directed, then it suggests very high probability of a structural defect of mitral leaflets being there and not just SAM causing MR. Based on all these abnormalities, we decide the management. But before we reach management, we have to also make sure that we are not mistaking other entities as HCM. And one common confusion arises between hypertrophic cardiomyopathy and hypertensive heart disease. Because if there is long-standing hypertension, it can lead to LVH and it may be ASH also. So if we have a patient who's got family history of hypertrophic cardiomyopathy or their marked ECG changes or LV is quite thickened more than 15 millimeter, if there is RVH, if there is severe diastolic dysfunction or MRI shows LG at certain specific points, all these features point towards the presence of hypertrophic cardiomyopathy and not hypertensive heart disease. The management of hypertrophic cardiomyopathy includes medications to reduce LV outflow obstruction. And the medications are negative inotropic agents such as beta blocker or diltiazem, which are the preferred drugs. In some patients, we use verapamil or disopyramide. Sometimes pacing is used. In fact, it was in use earlier, not used anymore. Mavacamten is and there are other drugs from the same group, which are a new class of drugs which can be used for reducing LV outflow obstruction in hypertrophic cardiomyopathy. Then in patients who remain symptomatic despite uh, using the drugs, the above mentioned drugs to the maximum dose that is possible, depending on the heart rate and tolerability, then we have to look at septal reduction procedures such as alcohol septal ablation or surgical septal myomectomy. And in every patient with hypertrophic cardiomyopathy, we also need to look at the risk of sudden cardiac death because that is a very, very important consideration here. And the patients who appear to be at high SCD risk, they need to be given a prophylactic AICD. So, what are the pointers towards the need for AICD? If the patient presents with aborted sudden cardiac death or documented sustained VT, then of course there is no confusion. But in patients who don't have any documented life-threatening arrhythmia, then family history of sudden death in a young individual, LVH more than 30 millimeter in any segment, more than one recent episode of syncope which appears to be arrhythmic in origin, LV apical aneurysm, or LV EF less than 50%. These are the indications for AICD implantation. Then there are some softer indications also like multiple NSVTs on Holter or more than 15% area fibrosis in LV on cardiac MRI. So these would be additional indication, but softer indications. All patients with hypertrophic cardiomyopathy need to have family screening also. All first degree relatives should be screened at least once, and there is a protocol given for serial testing in individuals who are younger than 50 years of age. After 50, we don't need to do family screening. And lastly, we come to restrictive cardiomyopathy. So restrictive cardiomyopathy is defined as a condition in which there is restrictive left and or RV pathophysiology in the presence of normal or reduced diastolic volumes, which means the cavity size of ventricles is small or normal or reduced systolic volumes, and normal ventricular wall thickness. So this third point is important, added in the latest ESC guidelines, because earlier we used to believe that LVH, if present, will indicate restrictive cardiomyopathy. But typical restrictive cardiomyopathy is associated with normal ventricular wall thickness. When wall thickness is increased, like in amyloidosis and infiltrative diseases, then we don't call it restrictive cardiomyopathy. This is known as restrictive heart disease. So basically, there are many diseases which can present with restrictive physiology. Not every disease is known as restrictive cardiomyopathy, but most of them will physiologically behave in the same manner. So there may be some genetic diseases which will be mainly restrictive cardiomyopathy, the primary variety. Then many storage diseases can present as restrictive heart disease, endomyocardial fibrosis, hypereosinophilia, carcinoid can present as restrictive heart disease. Then amyloidosis, sarcoidosis, radiation, diabetes, diabetic heart disease, they all also can present as restrictive heart disease. What happens in a respiratory heart disease is that ventricles are stiff, particularly the left ventricle, which impedes LV filling. So there is significant diastolic dysfunction. So there is increased LV diastolic pressure, which leads to increased atrial pressure. There is right atrial enlargement, which leads to pulmonary and systemic congestion. And patients present with either left side congestion features in the form of dyspnea, PND, orthopnea, or right side congestion features like pedal edema. And they may also have fatigue, weakness, palpitations because of AF. AF is a common occurrence in these patients. So, how to approach a patient with suspected RCM? There are two steps involved here. First is that based on echo, we determine that, okay, the patient has got a restrictive heart disease. Once we confirm that there is a restrictive heart disease, then we try to establish the etiology, whether it is a restrictive cardiomyopathy or EMF or amyloid or something else. So, what are the echo findings which will suggest to us that the patient has got restrictive heart disease? So, we need to have normal size ventricles with normal EF. The myocardial velocities in strain are reduced. There will be may or may not be LVH, may or may not be RVH. There's significant diastolic dysfunction, LV, RV. There's biatrial enlargement, mild MRTR. PA pressure is usually significantly elevated. There, there may be clots in the atrial appendages. There may be mild pericardial effusion. IVC is dilated and often non-collapsing. But we need to remember all these findings will only tell us that there is a restrictive heart disease. We cannot diagnose RCMP. Just on the basis of this, we need biopsy for proving that this is RCMP. Okay. So for first, we have diagnosed that there is a restrictive heart disease. Then how to reach an etiological diagnosis. So first is idiopathic RCM. This is actually a diagnosis of exclusion. We rule out other possibilities, and then if you don't find any explanation for the restrictive physiology, then we label this as idiopathic RCM. This may be sporadic or genetic. When it may be familial, as I mentioned here. It can manifest at any age. Survival time also varies, but mean 9 years. And here we have an example. LV, RV are of normal size. LA area significantly dilated. IVC is dilated, non-collapsing, restrictive physiology, and there was no other explanation. So we labeled this as idiopathic RCMP. These are the patients who will need genetic testing and family screening. The other very common respiratory heart disease is amyloidosis, and it is an entity which is very, very often missed and something which should not happen. So amyloidosis in the classical form will present at marked ventricular wall thickness. As you can see here, LV is hugely thickened. There is vital enlargement, there will be thickening of the leaflets, some degree of pericardial effusion, and restrictive physiology. But many patients may not have this extensive LVH. They also should not be missed. I'll come to that in a few minutes. But before that, what is amyloidosis? So, amyloidosis is a disease in which normally occurring proteins in our body become abnormal for some reason and they turn into their oligomers. These oligomers join each other to form fibrils, and these fibrils are deposited in various organs. These are known as amyloid fibrils. So, these are normal proteins which somehow become abnormal and form fibrils. Fibrils, when deposited in various organs, cause organ dysfunction, and depending on the organ which is involved, the clinical manifestations will occur. There are more than 30 proteins known which can cause amyloidosis. Only 9 of them involve myocardium, but only 2 are the main causes of cardiac amyloidosis. One is the immunoglobulin light chains, which cause primary amyloidosis or AL type of amyloidosis, in which myocardial involvement occurs in 70% cases. And the second is a protein called transthyretin. This is a protein which carries retinol and thyroxine in our body. So it becomes abnormal for some reason and then it creates amyloidosis. In it, this variety of amyloidosis is also two types. One is wild types occurring mainly in elderly individuals and the familial variant. In wild type, cardiac involvement occurs in every case, 100% cardiac involvement. So these are the mainly two forms of cardiac amyloidosis which we encounter in clinical practice. So whenever we see patient in whom we are suspecting cardiac amyloidosis, we have to basically look for these two entities. So what are the echo findings in amyloidosis? I showed you a very classical example in the previous slide. Here is less extensive LVH, but still you can make out there uniform LVH, there is global LV systolic dysfunction, vital enlargement, atrial septum also appears to be thickened. If we use Doppler, we'll find that there's restrictive physiology. In tissue Doppler, E velocity, A, and S prime, all three are reduced, often less than 5, which is known as 5-5-5 sign. So markedly reduced tissue velocity. If you use strain, we see a very typical appearance in which strain at LV apex is relatively preserved, giving the bullseye plot a cherry on top appearance. So it's very, very characteristic of cardiac amyloidosis. So what are the situations in which we should suspect amyloidosis? I mentioned to you that amyloidosis is commonly missed. So what we should do to not miss amyloidosis? So we should suspect amyloidosis in every patient in whom LV wall thickness is more than 12 millimeter, plus any one of these five findings, any one of these red flags. Heart failure occurring in a person above 65 years of age, aortic stenosis above 65 years of age, hypotension or normotension in a patient who was previously hypertensive. So patient says that earlier he or she was on multiple antihypertensives, but now BP has started remaining normal without medications. Autonomic neuropathy, peripheral neuropathy, proteinuria, skin bruising, people coming with bruises around their eyes, bilateral carpal tunnel syndrome, ruptured biceps tendon, or MRA abnormalities. So these are the conditions in which we should be suspecting amyloidosis if echo shows LV wall thickness more than 12 millimeter. Once we suspect amyloidosis, as I mentioned, we have to look for two possibilities, either AL amyloidosis or ATTR amyloidosis. So in all these patients, we get hematological tests in the form of serum free light chain assay and serum and urine immunofixation electrophoresis. The other test that we do is technetium pyrophosphate scintigraphy. This is a bone scan, but in ATTR amyloidosis, this picks up amyloid deposition in the heart. So these are the two tests that we do. If these hematological tests are negative, and scintigraphy is also negative, then amyloidosis, cardiac amyloidosis is
I
very
mean,
unlikely. If hematological tests are negative but scintigraphy is abnormal, then it is confirmed that the patient has got ATTR cardiac amyloidosis. No further testing is needed to prove the diagnosis. If hematological tests are abnormal and scintigraphy is normal, then it is AL amyloidosis. We need to then do biopsy to prove it. If both are abnormal, then it may be a mixed variant of amyloidosis, will require histological confirmation. Then briefly about endomyocardial disease. It is a disease entity characterized by two different phenotypes. One is Loeffler's endocarditis, which occurs mainly in temperate zones associated with hypereosinophilia. It is also known as eosinophilic cardiomyopathy. And the other variant is EMF, endomyocardial fibrosis, which occurs in tropical regions like South India. Exact etiology is not known, but it presents mainly as end-stage uh, cardiomyopathy. This uh, presents more often as a active disease, fulminant course. So here we have an example of Loeffler's endocarditis or hypereosinophilic cardiomyopathy. So as you can see, both ventricles are normal in size, both atrial dilated, and there is this obliteration of both the apices of the ventricles because of thrombus formation. And if we put color, we'll find significant regurgitation of mitral valve, maybe of tricuspid valve also. If we do eosinophil count, we'll find eosinophil count is quite elevated. So this is our hypereosinophilic syndrome or Loeffler's endocarditis. The endomyocardial fibrosis is a different entity which does not present with active manifestations. Patients will present with advanced forms of restricted heart disease. In 50% cases, there is involvement of both ventricles. In 40% only LV, and in 10% only RV. And here we have typical images. So as you can see here, RV apex is obliterated, and this indentation of RV free wall tells us that RV apex is obliterated. There is pericardial effusion. There is significant diastolic dysfunction of RV, which is resulting in blood stasis, and a large clot has formed in the RV. So this is a typical RV EMF. How do we treat restrictive heart diseases? So mainstay of treatment is going to be guideline-directed medical therapy. In some cases, we can use disease-specific management, as in case of amyloidosis. But in most of the other patients, the treatment will be either in the form of ventricular assist devices or cardiac transplant. So just to summarize, cardiomyopathies are very common, associated with significant morbidity and mortality. A comprehensive workup is needed for proper diagnosis, risk assessment, and guiding management. Thank you.
so it was a great talk, Dr. Manish Bansal. It was a great talk. Possibly, I would say that, it was a kind of summary of everything. I'll request you to, send us a synopsis or a summary of everything so that,
Yes, sir.
we are come out with a, a, a small compendium of whatever is being talked in this on this platform. So in the end,
Sure, sir.
maybe next coming CSI, as promised by Dr. Tiwari, we can have a compendium which can be circulated to large number of students and can be of great use. Those who have attended must have realized that, your talk was superb, and you have covered almost everything, right from simple things to complex things, and complex cardiomyopathies. You have shown very good echoes. That was a great thing. So any question from anybody, uh, like any question from anybody, like to role of immunomodulation in cardiomyopathy, somebody has asked. Dr. Manish, can you take up this question? Everybody
I'm
has
not,
complimented. Yeah.
yeah, I'm not aware of any role of immunomodulation in cardiomyopathy. In times to come, this will become a reality as we are going to use not immunomodulation, but gene modification will be treatment approach for cardiomyopathy. But I'm not aware of any immunomodulation for cardiomyopathies.
Thank you, Dr. Neha Kumari, for asking this question. Any other question or any other point anybody can make at this point of time? Only thing I would say that recently we had presented, we have published a case report on eosinophilic cardiomyopathy, because Shraddha must have talked to you regarding this paper of ours.
Yeah,
So,
yeah.
so to keep our eyes and ears open, if you are become a good clinician like Dr. Bansal, you have to keep everything open. So thank you all very much. And I thank you from my core of heart that you have agreed finally despite of your busy schedule. Thank you very much.
Thank you, sir. Thank you. Thank you. It was an absolute privilege for me. Thank you. Thank you.
Bye-bye.